சார் நீங்கள் மேலே நான் போகிறேன்.
Very good afternoon to one and all present here. May we all seated, please? So I invite you all to this special occasion, and I take immense pleasure in inviting these great minds that are on the dais today. So today has been a very big day for all of us. It's been a milestone in cardiology. For decades, cardiology and cardiac events and cardiac interventions, they have been evolutionizing for all of the past decades, and I'm grateful to be one of them among these to visualize these evolutions by myself, and I hope you all do too. So today, let's start this program with a Tamil Thai Varthal. Let's all kindly rise up for the Tamil Thai Varthal.
வாழ்வினில் செம்மையை செய்பவள் நீயே, மாண்புகள் நீயே, என் தமிழ் தாயே, வீழ்வாறு வீழாது காப்பவள் நீயே, வீரனின் வீரமும் வெற்றியும் நீயே, தாண்டிடு நிலையினில் உனை விடுப்பேனோ, தமிழ் என் நாளும் தலை குனிவேனோ, சூழ்ந்தின்பம் நல்கிடும் பைந்தமிழன்னாய் தோன்றுடல் நீ உயிர் நான் மறப்பேனோ, செந்தமிழே உயிரே நருந்தேனே, செயலினை மூச்சினை உனக்களித்தேனே, நைந்தாயனில் நைந்து போகுமென் வாழ்வு, நன்னிலை உனக்கெனில் எனக்கும் தானே, முந்திய நாளினில் அறிவுமில்லாது மொய்த்தனன் மனிதராம் புதுப்புனல் மீது செந்தாமரை காடு பூத்தது போல செழித்த என் தமிழே ஒளியே வாழி, செழித்த என் தமிழே ஒளியே வாழி, செழித்த என் தமிழே ஒளியே வாழி.
Thank you. Let's all be seated. So, a tiny catheter and a failing valve has brought great minds together on this day, and I now invite Dr. Mani, Dean AVMC, to give the welcome address on this special occasion.
Good afternoon, all. On behalf of faculties of AVMC and the consultants of VMSH, I proudly welcome Dr. Sengottuvelu G, a senior consultant, interventional cardiologist from Apollo Hospital, Chennai. He is an expertise in structural interventions and coronary interventions. It's a privilege, sir, for you to be amongst us this afternoon, sharing your expertise. Also welcome Mr. Suresh Samuel, Executive Council Member, Board of Management, VMRF. I welcome our Medical Superintendent, Dr. Damodaran. Welcome Dr. V. N. Selvam, Medical Director, VMSH. Mr. Manimaran, COO, VMSH. I welcome the Director of HR, Dr. David. Dr. Suresh Raman, HR, Corporate, Chennai. I welcome Professor HODs of departments of the clinical and the non-clinical departments of AVMC. Welcome the postgraduates who have assembled here to enrich themselves with respect to cardiology. A warm welcome to the students from College of Nursing and Allied Health Science. Thank you.
Without further ado, I am inviting to the stage Dr. Sridhar Balaguru, Consultant Interventional Cardiologist and Electrophysiologist, Vinayaka Mission, to give the introduction of the CME.
Good afternoon, everyone. It's indeed a proud moment for AVMC. So you should all feel proud that this institution is the first institution in performing a TAVR case in the private sector in the whole of Puducherry. This is a milestone for VMRF Puducherry campus, and it's a milestone for us that we are the first one to perform in the private sector, the first successful TAVR, and the patient is doing well, all thanks to Dr. Sengottuvelu. So it's my privilege to give an introduction of Sir. He is an alumnus of my own Madras Medical College. He has, after completing his MD/DM, he has done his fellowship in interventional cardiology from France, and he has FRCP of London and Glasgow to his credit, and he is also a fellow of Asia Pacific Society of Interventional Cardiology, Society of Coronary Angiography and Interventions, and Cardiology Society of India. And currently he is the clinical lead for the structural heart program in Apollo Hospitals, Chennai, and also the interventional cardiology program at Apollo Hospitals, Chennai. Sir is also the scientific advisory board member for Asia Pacific Society of Cardiology, and he is also the advisory board member of the Cardiovascular European Research Center, Asia. And he needs no great introduction. Every one of us can Google and see all his details. I'll just give a short glimpse of what he is doing. He is a key opinion leader in all complex coronary interventions and structural heart interventions in Asia Pacific region, based, and that too based in our own Chennai in Tamil Nadu. And he has contributed significantly to research and innovation in this area of cardiology, and he is also editorial board member of the Asia Intervention Journal and the Indian Heart Journal. And the most popular course with regards to heart valves in India, the famously called India Valves program, is being organized by him. He is the director of the Heart Valve Foundation of India and the founder course director of the India's largest transcatheter heart course, India Valves. And I would like to mention that the next India Valves is going to again be held at Chennai. And he is the founder director of Imaging and Physiology Council of India. Sir has numerous accolades for his contributions. I can keep on reading a list. I don't want to waste your time. We want to listen to sir. Just to highlight certain outstanding awards. One is a CRT Young Leader Award from Washington, CCT from Japan, and Distinguished Research Award from AHL across others. And please note this, sir is a gifted teacher. He has performed several live demonstrations, proctored several physicians, and he is responsible for starting the TAVR program in several locations across the country as well as across the state. And now we are also forming part of it. So he is the person who has proctored our first TAVR case. So thank you, sir. Thank you for giving us this opportunity and handling the case in an excellent manner. The patient is doing extremely well and we are all happy. I invite sir for giving his talk.
Thank you so much, sir. So now I take immense pleasure in inviting Dr. Sengottuvelu G to give the story of TAVR. Now he will be on the stage to give you the special story. As we all know, in medicine, every generation witnesses innovations that redefines what is possible. So today we aim in exploring this groundbreaking minimally invasive intervention that has transformed this treatment of aortic stenosis. So transcatheter aortic valve implantation, it stands as one of such milestones, bringing new hope to patients with aortic stenosis who once had limited treatment options. So without further ado, I invite Dr. Sengottuvelu sir onto the stage, please.
Good afternoon, all of you. Good afternoon, all of you. So it's a great privilege to be here today with all of you, and I would like to thank the management, the board of director, Dr. Suresh Shamwell, the Chancellor, Dr. Ganesan, and the Dean of Faculties and all our management. And first of all, I would like to congratulate all of you to having this wonderful hospital. Very impressed with all the facilities here. And we would like to again congratulate the team today, the cardiac team, led by Dr. Sridhar and Dr. Gopal Subramaniam, who did a fantastic job today in doing this first case, TAVI. So it is a real milestone for this region, because we have given the best possible valve with the best possible result today. I will talk to you a little more detail how we choose this best valve for this patient today. So today I'm going to talk to you on how we started the TAVI program in the country and how it evolved in India last about more than 10 years now since we started. So the TAVI, we know that aortic stenosis is quite a prevalent disease. It is quite common in elderly people, because we are talking about degenerative aortic stenosis. We talk about rheumatic valve disease, which is often seen in more younger population. But what we are seeing is now, as our population is aging and we are seeing more people living over 70s, 80s, we see more patients with degenerative calcific aortic stenosis in mitral valve disease. So really it was a boon that this is one of the, I would say, one of the greatest wonders of modern medicine, this TAVI, because during my undergraduate days, I never ever thought a valve can be replaced percutaneously without surgery. But today it is possible thanks to all the new efforts. I would like to mention that this is Professor Alan Crevier. This was year 2002. At the time, I spent some time with Alan Crevier in 2002. That is time before he did the first. It was 2000 TAVI. So I was with him about a year before that. And at that time you can see the person who's on the right side of the screen, he's Professor Alan Crevier. So he's in Rouen, France. He was the one who did the first TAVI in the world in 2002. So this is again during the time when I spent with Professor Alan Crevier. He first, for a patient who was refused surgery, he was in a terminal illness, he was bedridden, and this patient had no other hope. So they did a procedure. It was a very primitive procedure. They used a valve, their own, and they put a valve through the venous system, through the septal puncture. They introduced it to the left heart from the introduced it antegratally and put the first valve in 2012. And subsequently, patient did well. The first patient did well. Patient died after many years later due to a fall, not because of related to valve issue. But then people initially didn't accept it. It took some time for it to get established, to get the time to the valve, and it took almost 7-8 years for people to start recognizing his work, and then started doing TAVI. So today, if you fast forward, the TAVI has come a long way with so much of experience in both our experience as well as advancements in technology and training. And today it has become a very strong class 1 recommendation. Class 1A recommendation is one of the highest scientific evidence we can give based on the evidence. It is now the first choice therapy in patients with severe aortic stenosis who are symptomatic. And initially the TAVI patients who are inoperable are extremely high risk for surgery. And then we move to patients who are intermediate risk. And now even patients who have an alternate for surgery, we are offering them TAVI as an option for aortic stenosis. So what is TAVI? TAVI is Transcatheter Aortic Valve Implantation, or in the US they call it as TAVR, which is Transcatheter Aortic Valve Replacement. Both are the same, and it's basically replacing the aortic valve without surgery through a small incision. That's how we did it today. Stenosis is valvular condition which gradually starts, and for a long period of time, even when the patient develops severe aortic stenosis, they remain without any symptoms. And we can have a long latent period before they develop severe symptoms. The typical symptoms of aortic stenosis are breathlessness on exertion, angina, chest discomfort on exertion, and sometimes even syncope, which we call it as fainting, and particularly even during exertion. These are typical symptoms of aortic stenosis. But as I mentioned, there can be long period of symptoms, but still we have severe aortic stenosis. In the early period, we were only suggesting that patients who have severe symptomatic aortic stenosis should undergo TAVI, but today with the new evidence available, this is evidence from New England Journal of Medicine, which shows that TAVI can be performed in even asymptomatic patients with severe aortic stenosis, and they've been shown to have great benefit. So now if you look at our country, we have a large population, we have an aging population. It's about almost India is home to 20% of the world's population, one of the world population, and our TAVI growth was slower than expected. But currently we are now we are increasingly seeing aging patients, and now we're having more patients who require TAVI. One of the things with what we see here is we see patients who are requiring TAVI even at a younger age compared to the Western world. And so the healthcare system is again different. We know that we have higher costs and we don't have reimbursement, and many other issues are there. So if we look at our journey, TAVI was, we had to, when we started TAVI 11-12 years back, we had to screen patients, find the patients who are really in need for TAVI, and then we apply for license. We don't have valves available, and we have to import we have to import the valve, and then we have to wait, and then we have to do the TAVI. That's what, when we started in 2015, it was like that. So subsequently, we had to have proctors who come and help us to do TAVI. That's how we learned TAVI over a period of time. And then, over a period of time, the two valves which came available in the country. And in 2017, we were part of a first-in-man study using an indigenous valve made in India. So first-in-man trial, we did about 30 patients. We did a valve with our own Indian patients, the indigenously made valve. And there were challenges in doing these cases because it is a differently developed valve. There are issues with the access site, which required a larger diameter, larger bore catheters, which needed increase the risk of bleeding. So with all that, we had done a few cases, and then slowly the valve we found it was very successful. Many cases went very well. So subsequently the valves were modified, and the indigenously really helped with cost, and we are able to offer to many patients. So then the growth was exponential because many number of valves were available, the Indian-made valves were available, and then many centers started doing. So we were traveling to many centers and doing cases, and subsequently centers, smaller centers are now started doing, and the growth of TAVI is really exponential. In India, it is expected to go even further in the next few years. So again, the number of valves, what we have seen is again a number of new valves available, and today what we have used here in this hospital today is one of the latest generation valve in the world. That is the best valve today available in the world, and it's most commonly used valve in the United States, which is the Edwards SAPIEN 3 Ultra Resilia valve. So these are the new launches, and we have most of these valves are available. And if you look at the number of valves, the Indian valve is one valve which is very often used, and the valve procedures are now increasing, and it's almost there are about 450 centers. 450 plus centers who are doing more than 50 cases every year. And one of the big challenges we have is if you look at our life expectancy, India still it is only 67 years, and hence we are offering TAVI to even younger patients. That one of the reasons is because our life expectancy is much lower, so we don't have to look at the Western guidelines, and we have our own ways of offering this patients. So aortic stenosis, if left untreated, has a very worse prognosis. It can be worse than the form of the worst metastatic cancer, which means the survival is very poor if we don't treat them. And whereas it is completely treatable, and when you treat these patients, they can quickly go home and get back good quality of as well as survival. So TAVI needs more than strategic planning. It is not just for acute results. I could tell that we were discussing with Dr. Sridhar about today's case. We were earlier when we started doing TAVI, we were really concerned about giving a safe and acute result. This means patients should walk home safely from the hospital without any complication. That was the goal. But today our goals have changed. We are looking at a long-term perspective of what the patient is going to do the next 15 years, how the valve is going to be. These valves are tissue valves, and tissue valves can get degenerated over time. In the lifetime of the patient, how long this valve is going to last, and whether what to do in this lifetime. Today we have treated a patient who is 70 plus, and what is the future for that patient? So we look at, we should not aim to give a pacemaker, to give a what a patient processes mismatch, which means we want to give the right size and it's good hemodynamics, which means the best possible result at the procedure will translate to better long-term results. So we focus on giving the lowest gradient possible. Gradient is the pressure difference between the valve and the stenotic valve, and we have the least pressure difference that translates to better long-term outcome. The acute result is what we don't want is we don't want a stroke or a bleeding or sometimes a kidney injury, which can happen if the valve is not planned well, it can happen. So how do we do all this? We reduce the pacemaker risk from planning the valve, choosing the right size of the valve, positioning the valve with appropriate height, and we have many new refined options of placing the valves depending on the type of valve. So we land the valve in such a way that the conduction system is very close to the aortic valve, the septum, the membranous septum. We don't want injury to the conduction system. That's why we implant the valve quite high, so the risk of injury is much lower. Similarly, the risk of stroke is about 3 to 6%, and we have many ways to reduce the stroke. Many devices, dedicated devices available, like what you can see in this picture. It is a filter, what we call a sentinel device, where we can place these filters and then remove it if there is any embolization. And this is again one of the patients where we did cerebral protection. We removed all this. Most of the time when we do TAVR, we see some of the filtered materials from the filter which would, if we have not placed a filter. It does happen. And also, as I mentioned, we are also trying to create a situation similar to the normal physiology of the person. So we place the valve, which we call it as commercial alignment, to the natural position, so that it just mimics a natural situation for the patient. So, we are also nowadays doing for failed surgical valve, where the surgeon's valve is again a tissue valve which can last only about 10-15 years, and then can fail valve. We can place. We are also nowadays reducing the contrast, which is the dive which we give during the procedure. There's one of the patients we use zero contrast, which means without any dive we are able to do TAVR using ultrasound and MRI guidance to size the valve and then position the valve. We are also doing now for severe aortic regurgitation, not just aortic stenosis, for severe aortic regurgitation, but we use a conventional valve, oversize the valve, and then do it. Also, the dedicated devices available, particularly for pure aortic regurgitation. And this is one of our patients where we use a valve with a huge sinus aneurysm, valve valve, to is a very high risk patient which we were able to treat with TAVR. I'll show you quickly some of this. Is one of simultaneously with aortic and mitral valve in the post, but with severe multiple valves and multiple comorbid conditions. So we received 2 valves, which is valve and valve for the mitral and the TAVR for the aortic. So there are now new devices. Sometimes what can happen is a peripheral access site may be challenging, it will be very narrow peripheral access site, so it will be difficult to take those big devices. So patients can have severe calcium. We use something called intravascular lithotripsy, which is we create more passage by breaking open this calcium, and so it can allow the valve to pass through the iliac arteries. So the number of different valves are available today, and the Indian valve is the one valve which is frequently used. It's called MyValve, and they have newer generation valve called the MyValve OctaPro. The Sapien 3 is a valve from Edwards. It's again a balloon expandable valve. There are different types of valve. One is a balloon expandable valve. The other is a self-expanding valve. There's a self-expanding valve which is called a Navita valve. We'll just quickly pass through different types of valves. We have about 7 or 8 valves now with this. This is again a cerebral protection system being deployed. And there's one more Indian valve called Hydra valve, which is again available. This is a self-expanding valve where the valve expands by itself. Sometimes we need to come angioplasty with TAVR. This is the patient we did a left main angioplasty, lineman bifurcation with TAVR, and this patient did well. So now what patients what we do is we try to simulate and in an atmosphere where we can find the best possible valve for that particular patient. So we can precisely plan the procedure. I always say that TAVR is about 70-80% planning and only 20-30% execution. So a lot of planning is really required. And this is actually a CT scan angio image where we can use it to merge both and plan it during the procedure itself. We can use a CT to help position the valve and assess the annulus and the sizing. This is color coded. You can see the left ventricle blue and the aorta in yellow. The CT and the pleuro which is combined together. And so this is possible when we combine both. We can have the software within the cath lab. There are some, quickly I can show you some of the valve designs. This is a valve, made in India valve called the MyValve Octocar. And this I would like to show. See, the other problem can happen is if the valve is not sized well, the blood can leak back in the same direction because there will be gaps between the valve, the new valve and the annulus. So the technologies have now, if you look at this, this is again a smart PVS sealing. It adapts to the annulus of the native annulus of the aortic valve. You can see there is no gap, so that it can get adapted to whatever shape of the annulus is. Most of the time it is not circular, it can be oval, and when it gets adapted, the risk of this kind of a leak or a paravalve leak is very much reduced. The other new type of valve which we implanted today is, as I mentioned, the Sapien 3 Resilia valve. Why this valve is important, or why the valve makes a difference? Because the valve is actually a metal frame, and this valve is a bioprosthetic tissue, usually from either a porcine or a bovine tissue. And this is a bovine tissue which is stitched into the metal frame. That's how they make this valve. And this bovine tissue, just like any other tissue, can get degenerated over time. And if you look at the durability of the valve, literally depends upon how long this can remain intact and the valve function can be intact. One of the main reasons for valve degeneration is deposition of calcium in the leaflets. And that can happen even just like how a natural normal valve calcifies. Similarly, an implanted new valve also can get calcified, and because of the wear and tear. So how do we avoid? One is giving a good result. Second, the leaflet tissue. Now they have found out that this is the main reason for calcium deposition is they preserve these valves with aldehyde solution. Free aldehyde, what happens is it attracts calcium, and that increases the valve degeneration. And hence now we have valve which is preserved without aldehyde, and this is one of the new tissues which is called Resilia tissue, which is preserved without aldehyde, and that's the main focus today what we have done in this case also. So this Resilia tissue is a new evolution where the risk of calcium deposition is very well reduced, and so hence compared to a traditional valve, the durability of the valve is far higher. So this valve can even last up to 20 years or even more. So then moving to further new advances, this is one of the cases which we did live to one of the meetings where we do there's a very complex calcified bicuspid with horizontal aortic anatomy, very anomaly, it was different anomaly. So we use a 3D printed heart, and we created a model, and then we put the valve. This is actually in vivo outside the lab in a model where we had customized the same patient's anatomy was exactly printed 3D, and then we were able to introduce the valve and then go inside and see whether that fits in well for that particular anatomy. Because it's again, as you know, human anatomy is complex and it is very different for each individual, and we were able to fit this in that 3D printed model. We were able to get the right size, and then we were able to take it to the patient. The same patient we demonstrated live. This was about a few years ago, which we used for 3D printing. And now we also have this finite element analysis. This is again now with AI coming in. There are a number of AI advances helping us. Like for example, we can put in our patient and find out who are the patients who are going to having a high risk for heart block, who are the patients who have a high risk of coronary occlusion. We can identify, and who are the patients who are going to result in higher risk of paravalvular leak. So those things, if we can identify the high risk subsets, then we can modify our plan, change our plan to size the valve differently, or even position the valve differently to suit the anatomy, so that we can get the best possible results. So again, moving to vascular access and closure, again, it's a big bore access. Normally, in the early days, we were using a cut down with a vascular surgeon opening up the artery, and then you visualize it and take the device. And today, the technology is so advanced, we use percutaneous device. We use a suture, which is again done through percutaneous method, and then you don't have to do any cut down. You just have to knot put the suture in and knot it, and so patients can walk the next day itself. In fact, today also, if patient who we did today can walk in the evening, but just as a precaution, we keep them one day immobilized, and tomorrow morning they walk. It's a high pressure situation, so no cutting open. And with that, now several new devices come, like the Manta device, ProGlide. Today we use a ProGlide device, which really helped in securing the hemostasis immediately after the procedure. So now we are also moving more to minimally invasive TAVI with very minimal local anesthesia, conscious sedation. We call it as conscious sedation. Patient is alert and the patient goes home mostly next day. Even if we want to send the patient the same day, we are comfortable, but patients really want to go home earlier. They want to stay at least 2 days in the hospital. So the technology has evolved in such a way that we are able to discharge them quickly with the best possible results. So to conclude, the TAVI has gone through a lot of changes in the last decade, and we have been through this in the last decade, evolving through an entire period of this year. We have learned that now TAVI is not a procedure which is going to help immediately, but also over a period of time, lifetime of the patient. So we need to look at the lifetime management with very good outcomes. Now we are also moving to younger patients, and now with new tools and new generation valves available, with new imaging modalities, with AI and all, we are able to predict the complications and then appropriately prevent it or reduce the risk. And so we are able to give a very good result in even the younger patient. So thank you, and with that I would like to conclude again saying that today's patient received the best possible valve, the resilient tissue as I mentioned, and the patient didn't have any good hemodynamics with very low gradient, no paravalvular leak, patient didn't require a pacemaker, and this patient will likely, she can move home tomorrow, but as a matter of precaution, we're going to keep her one more day and we're going to discharge. Dr. Sridhar is going to discharge day after tomorrow. So thank you again for your patient visit. I'm happy to take if there are any questions, otherwise.
Sir, good afternoon, sir.
Yes.
So what will be the roughly the cost of this procedure?
Oh, sure. Okay, so as I mentioned, the valves have changed over time, and the presence of Indian cost varies depending on the valve. And fortunately, thanks to the indigenous development, the valve costs are coming down. Generally, the valve what we use today is, as I mentioned, is one of the top most valve in the world. So it's expensive. The valve alone costs us somewhere around 22 lakhs. But in the Indian valve, we are able to get the valve alone for about 10 lakhs. So it will be significantly less with Indian valves. But again, the cost will come down once we have more type companies developing the valves indigenously.
Congratulations and thank you, Dr. Sengottuvelu. This is Dr. Ilangovan. Yeah, I'm here. I'm asking this question. Very often we see a lot of rheumatic heart disease patients. We are able to do a balloon, but we are left out with an aortic stenosis. Now, can we combine balloon mitral with an TAVI, and do you have any experience like that?
One of the challenges with rheumatic aortic stenosis is it doesn't cause calcification. So it's a non-calcific valve. You can ask me, how does a TAVI valve just stays there without moving up or down? Normally, the surgeons they do a suture and they make sure the valve stays there permanently. Whereas when we put the valve in, the valve stays there. How does it happen? Because presence of calcium is necessary. Calcium helps to anchor the valve in place. It's like you have a calcium, it just holds the valve. There's some calcium protrusion coming into the valve frame to hold the valve. The rheumatic aortic stenosis, the problem is the lack of calcium. challenging, and we have treated rheumatic aortic stenosis. Generally, most of the patients you talk about are younger patients who have rheumatic mitral and aortic stenosis. When you have very young patients like the 20s and 30s, we have to give them a little longer durability, which can only be done with the mechanical valve. You want to put a tissue valve, yes, but this tissue valve, like a TAVR valve, will last only about 15 years. That's one of the main limitations giving this to very young patients. But how we treated rheumatic aortic stenosis is to oversize the valve. Instead of putting a regular size, we oversize the valve by 30% or 40% more, so that even if there is no calcium, the valve stays in place. That's why we oversize and place it. And that is done only in patients who are old patients or younger patients who are unfit or not suitable for surgery. If they are suitable for surgery, for young patients, still surgery is the best option.
Among all these valves which you have shown, which one would you recommend? No, I know that the cost is a big issue, but what I mean is, for a bicuspid valve...
It's a very good question. The reason is, that again, there are 7-8 valves. 80% of the patients can receive any type of valve. But there are some 20% for whom a particular type of valve may be better. For example, if they have a lot of calcium which is extending into left ventricular outflow tract, and if you put a valve, the risk of rupture is slightly higher. In those situations, we put a self-expanding valve, which the pressure exerted by that valve is much lower than a balloon expandable valve, which is where the pressure exerted on the left ventricular outflow is higher, the risk of injury is higher. So similarly, there are small differences where we can use certain type of valve which is better for that particular anatomy. So sizing also matters. So for today's patient also had some amount of LVOT calcium. So we had really looked into what type of valve. We finally decided for a balloon expandable valve, and we sized it accordingly and placed it very high so that we reduce the risk of left ventricular outflow tract pressure. This patient, particularly today's patient, had a very small left ventricular OT size. LVOT size was very small compared to annulus. So if we keep the valve down, and the oversized valve can cause injury because there is already LVOT calcium. So we place the valve very high to avoid that risk and also reduce the volume to reduce the risk.
I congratulate you and thank you very much. I can also congratulate Dr. Sridhar and his team. Thank you. Thank you.
So good morning. Good afternoon, sir. I'm Kiran from the MSc Cardiac Intervention Technology. So my question is regarding the complications. So whether it may be a coronary intervention or valvular intervention or device closure, whatever else is, so complication plays an important role in that. So while we are doing a transcatheter aortic valve replacement or implantation, what are the chief complications we may expect? So, and my second question is, what is the most worst complication that you faced in your career, and how about your mindset during facing that kind of complications?
Yeah. See, I'll tell you one thing, complications will come due to volumes. If somebody says no complication, they're either not doing or they're lying. So any big institution, big volume, we have had complications about 1%, but fortunately, when we do high volumes, over a period of time, we tend to reduce the risk of complications. So the major complications what we have encountered is out of about 405 patients. Recently, I had a patient with massive stroke just the last 2 weeks ago. It was a patient who was referred from Trichy, about 70 years old lady. We did a TAVI went very well, excellent result. They were very happy. Patient shifted to ICU. Within 1 hour, about half an hour, 40 minutes, they give me a call. The patient has dense hemiplegia, a stroke where they can't move the upper limb, is not able to talk, and both the left and upper limb is completely gone. If this had happened about 5-10 years ago, we would have just managed it conservatively. But today, being in the special center, we were able to have access to many other specialities. So immediately we called the neurointerventionalist, who was taken to cath lab immediately. We did an immediate angio, an immediate mechanical thrombectomy was done. And within 2 hours, the patient came, and the patient walked home and absolutely normally. She came for review last week. She's talking, normally walking. So if you have a complication, it's possible to manage. So there are some situations we have bailed out. Sometimes the sizing is an issue. You have to size the valve very correctly. If you oversize it, you can cause an injury. If you undersize it, there can be a valve leak. So again, over a period of time, we know that how to size a valve. With more, as I mentioned, planning is more important. So if you size the valve correctly, the complication rates are much lower. So what we have learned is, proper planning, proper planning. More important planning than only execution. So if you have a clear plan what to do, the risk of complications can be reduced. And with the availability of newer devices like the AI and all that, we can predict who are at higher risk for complication, and that particular patient we can modify our strategy.
Thank you so much, sir.
Sir, good afternoon, sir. This is Dr. Manideep, sir, medicine postgraduate. Sir, why we need to do pacing in TAVR? And second question is, you told as a branches will pass like bundle branches, how often will we get the blocks in the TAVR procedure? And post-discharge management, how it will be, sir?
Okay. So what is your first question?
Why we need to do pacing in TAVR?
Great. So normally what happens is, there is ejection of blood during systole. From the heart, the blood moves into aorta for circulation, into the brain, into the rest of the body. So it happens while ejection. During ejection, what is the tremendous amount of pressure created in the ventricle? You know, the systolic pressure is normally 120, 130. So at that pressure, the blood is ejected. And you want to place the valve just at the outlet where the blood comes out of the heart. If you place a valve and if the blood ejects at that pressure, what will happen? The valve will fly and go into the brain. So you want to slow the speed of the blood. How will you do it? How will you reduce the heart? You want to stop the heart. How can you stop the heart? So we do rapid pacing, which means pacing is, we give an electrical impulse. Normally the heartbeat originates from an electrical impulse and gives a beat, so every heartbeat happens. So when you drive with the electrical pacemaker, we give frequent stimuli, the heart will start beating very fast. When it beats very fast, there will be no ejection because there is no time for blood to fill and blood to eject. So effectively there will be no blood coming out of the heart. So during that particular time, we will be able to place the valve and fix the valve. So that is why we do rapid pacing. Today we did rapid pacing at 200-220 minutes, so heart almost stopped, and quickly during that time we implanted the valve. And then we stopped the pacing and the heart stops beating. That's the reason we do a fast pacing. And your second question?
Sir, as the bundle process.
Yeah, so the current originates in the SA node, which is in the right atrium. And then it goes, and there is something called AV node. There is a delay. And then the current type divides into left bundle or right bundle. So this is very, very close to the aortic valve. They are the non-coronary signs in the membranous septum. So when you place the valve, that can, even in elderly people, most of the time they will have degeneration and will have some conduction disturbance. If they have a pre-existing conduction disturbance, the risk is even higher. Today's patient had a pre-existing conduction disturbance. We were anticipating the need for pacemaker. I mentioned, we were discussing with Dr. Sridhar, mostly this patient would require pacemaker where 50% chance, because already the current was very slow. But since we placed the valve very high, actually it didn't change. Still she has the same amount of conduction disturbance. It's not aggravated. So we can still want to wait and see. If it still persists, it remains like that, we probably don't have to do a pacemaker. And your third question is what?
Post-TAVI management.
Okay, post-TAVI management is very simple, because these patients, when they have no coronary disease, no other need for any anticoagulation, they just on one aspirin medication, that's all. They don't need anything, aspirin, and they go home and like no other medication required. Unlike the stents where you need multiple medication. Just an aspirin and no other medication required. Unless they have any other comorbid illness, anything else, they may require some more medication. Otherwise, just only aspirin. Mostly this patient will go home only with aspirin.
Sir,
and a small dose of statin.
If you place it up, is there any chance for any leak or misplacing?
See, the valve is again, the valve has got different ways. They put a skirt in the lower part of the valve so that the leak can be reduced. So there are advantages of placing the valve deeper inside, above. So I'll tell you why. If you put it deeper, the risk of pacemaker is high, I mentioned to you, because the current system can get affected if you place deeper. If you place it high, you're going near the coronary artery. I know, I should show you images, you will understand, because coronary arteries are arising very close to the aortic valve. And you place it high, you are going to near the coronary artery. So when you place the valve, the native aortic leaflets can go and block the coronary artery. So we need to study the CT scan. CT is a must for every patient who has a TAVI. And then depending on the anatomy, depending on the size of the aorta, size, whether it can accommodate the height of the coronary, then we decide whether to place it high or low. So in this patient, it is all suitable, so we place it high.
Thank you so much.
Any other questions from the audience? Anyone else? Okay, thank you, sir.
1 minute, one question.
Let's all give a warm round of applause to our keynote speaker.
Yeah, if there is a patient has already undergone a bioprosthetic valve, can we do a valve in valve?
Yes. So, patient has undergone already a open heart surgery with the tissue valve. So, whether he can go for second with a TAVI? Yes, definitely yes. The reason is already one patient has gone through one open heart surgery, and subjecting him to second open heart surgery is much more riskier. TAVI is much more simpler procedure. And another advantage is there's already a metal valve already stitched by a surgeon, which is helpful for us to anchor the TAVI valve. So it is only the risk is those patients with post tissue valves have a very high risk for coronary occlusion. Normally the risk is 0.5%. In a prosthetic valve it's up to 2 to 3%, which means about 3 times higher. So we need to study the coronaries, we need to study the type of valve what they have put, and sometimes the valve may be smaller, so we need to fracture the old valve, make it bigger, and then put a TAVI valve. Yes, it's possible. And not only that, currently there is also a number of cases happening where TAVI in TAVI, which means, as I mentioned, this TAVI can last for about 10-15 years, and we are seeing some small population in about 10-20%, they even present early with regeneration. In such patients, we can even do one more TAVI in the same patients who had already TAVI, provided they have the anatomy suitable. The major problems are coronary occlusion. The second problem is they can have re-access problem. Once you put a second valve, the difficulty will be there to engage the coronary if you want to do a coronary angiogram later. So coronary access problems. See, these are the two major challenges we want to do TAVI in TAVI. And today that's a hot topic in interventional medicine.
How often you protect a coronary with a wire?
As I mentioned, it all depends upon the anatomy. In our practice, we do about 10%, and there are the coronary protection only can help in some situation, because you have to bail out. If there is a coronary occlusion, you have to put a stent, and that stent has to be a chimney stent, where the side of the valve stent will be there. And to re-access it later, or if there is any issue in the stent, it's very difficult to re-access.
You go radially or femoral?
No, we go radial, and we need 3 access.
For coronary protection.
We can do either. Similar, just like how you do PCI, we can do either femoral or radial. No. But generally in a
you already have the access for TAVI.
So that's what I'm telling you. For a TAVI, we need 2 access. One for the pigtail, one for the primary access. For a PCI, we need additional access. So we need 3 access. So we can do 2 femorals and radial. Out of which we can use either for pigtail, we can use radial, and then we can use a PCI femoral also. So that we can vary. But you can use either radial or femoral, but we need 3 axes.
We have done any transapical?
Yes, we have done. It was nowadays it's given up almost, but this was done about 7-8 years ago. A patient who was a post-bypass surgery is not suitable for access was poor, and we did a transapical with a direct puncture of the left ventricle, and with the support of a surgeon. We were able to put a catheter inside and directly put the valve. We did a patient with the transapical, yes.
Axillary, subclavian.
We have done axillary, we have done subclavian, we have also done a trans-aortic.
Trans-venocaval and then enter.
We have not done a transcaval, but we have done other access. But the important thing is, whatever access site we use, the survival benefit is the maximum. It's shown with transfemoral. So current understanding is that even if you have difficult femorals, it is better to use a IVL, or if you do peripheral angioplasty and still go with femoral, because that has been shown to have the best survival rates. So transfemoral is the first primary access, even with the challenges. Unless the arteries are very small, we don't try to go to alternate access. But of course, all these possible, even trans-carotid access is possible, and as you said, transcaval access is possible.
You are not done.
Transcaval you have not done, but other accesses you have done, yes.
I thought it appears very easy to do a transcaval.
Transcaval is easy, but the problem is the anatomy should be suitable. Because if you have calcium entirely in the aorta, because you have to puncture from the IVC into the aorta, and if you have calcium, and it's very difficult to later close with the device, with the device. So we need to close with the device. So the challenge is getting a good spot, sweet spot in the aorta by the CT.
What is the future of native mitral valve replacement?
It's very actually now with the new valves coming in, there are plenty of new dedicated valves available. The problem with mitral valve is a mitral valve is a very complex structure, unlike the aortic valve. So we call it as mitral valve apparatus. So it's got the leaflets, it's called the chorda tendineae, it's called the papillary muscle. So we need to have a complex mechanism, one to anchor the valve and then put another valve. There are a number of new valves are now available. The Sapien, now this is called the Sapien M3, that's a new valve for mitral. And please attend our India Valves in September. There's going to be a live transmission of dedicated mitral valve. So we are going to show that.
Tendine?
No, this is Edwards Sapien M3. Tendine is again another valve from Abbott.
Tendine is transapical, right?
Transapical. Now they are also having through transseptal also. But the new valve, Sapien M3 is from the transseptal function.
The day will come, we will say goodbye to surgery.
No, but we need the surgeon's help. Whatever it is, the surgeons always
when we are in trouble.
The surgeons to bail out our problems. Yeah, always the surgeons are there. Part of Dr. Gopal Suran was there with us. Yes.
Okay, that's it. Anyone else? Okay, thank you, sir. Thank you for this wonderful speech you've given us. Let's all give a big round of applause to sir. Thank you, sir. We are honored to share this space with you today. Sir has shared with us his precious sweet pearls of wisdom today about the history, the evolution, and the growth of TAVR today. So let's, without further delay, let's invite Dr. Noel, cardiac anesthetist, VMSH, to give his introduction speech for the next speaker. Thank you, sir.
Good evening, everybody. Thank you for the great talk, sir. And as of now, it's my great privilege to introduce Dr. Gopal Murugesan, an eminent cardiothoracic and vascular surgeon with an illustrious career spanning over 25 years. He has performed more than 10,000 complex CTVS surgeries with expertise in advanced procedure, including aortic aneurysm repair, root enlargement, redo CABGs, valve repairs and valve replacement, aortic procedures, lung resections, and ECMO support. He has also served as a senior consultant in leading tertiary cardiac centers, including Mayo Hospital and Frontier Lifeline Hospital, and has been instrumental in establishing more than 5 CTVS units across India and in the Fiji. And he has contributed significantly to the expansion of advanced cardiac surgical care. He is known for his surgical excellence, leadership, and dedication to patient care, and he continues to inspire the next generation of cardiac surgeons. Please join me in warmly welcoming Dr. Gopal, sir.
Good afternoon, everyone. Thanks for introducing me, Dr. Noel. My dear colleagues, friends, students, and my teachers, it is a privilege for me to talk in this stadium. Now, since Sir Sengottuvelu has spoken very well, and he has established that the only possible way of addressing the aortic stenosis is by TAVR. Now I am in a position to tell that still we are also there, we are not in the background, and we are also there to do some decent work. And there are definitely there are some difficulties for surgery. Surgery, when I speak to the patient, I tell that surgery is demolishing a building and reconstructing a new building. And if you want a touch-up work, you can just go for a minimal work and get immediately, because these patients also I told, if you want to walk tomorrow, you adapt for TAVI. If you want a extensive this thing, you have to come for surgery. But patient chose the next day, she want to walk around and go home, so she has accepted for that. So the primary objective which I have understood now is very simple, that we have become a background for cardiac work. So I accept that one, and we have chosen this topic, this small aortic root and aortic root enlargement, because we know that world is moving towards minimal access, and whatever you tell, whatever the way you do surgery or this thing, patient benefit is the mandatory, and patient will opt for the minimal access. So TAVI is going to be the future. So how we are going to support the TAVI procedure, that is how the surgeon has to think over now, rather than we have to be in harmony in developing a conducive atmosphere for future procedure. So as you know that still the gold standard for aortic stenosis is a surgical aortic valve replacement, but certain problems are there. As Sarah has told already, whenever you do a surgery, when you put a valve inside a diseased valve, you excise it and you size it and put a valve inside the diseased valve, you are going to encroach into the already narrowed aorta. So there will be some sort of patient prosthetic mismatch will be there. So the things when you are doing a surgery, two things you have to have in your mind. How to avoid patient prosthetic mismatch during surgery. Number two, this patient will definitely go in for a TAVR, because most of the patients are adapting for a bioprosthetic valve rather than a mechanical valve. So now we have to give the chance for this patient, since the science is becoming very developing day to day. So TAVI will be there for the future. So all patient, if at all the valve development is very positive, then we have to give the TAVI as an alternative. So patient prosthetic mismatch is usually you see a valve, the effective orifice area that has to match with the basal ring of the left ventricular outflow tract. So if it is a mismatch between the effective orifice area and basal ring of the left ventricular outflow tract, then there will be a discrepancy, then there comes the patient prosthetic mismatch. If it is less than 0.65 centimeter square per meter square, that is going to be severe. If you don't address the PPM properly, there will be no regression of left ventricular mass, and there will be myocardial dysfunction will be there, systolic, diastolic, and heart failure will be there. So this is the anatomical picture with the CT scan and echo. Whenever you are seeing a patient with aortic stenosis, if the valve size is annulus is less than 21, you have to do a CT scan or minimum of transesophageal echo with a 3D reconstruction, because this yellow line which is there is the surgical ring where our valve seats, and the TAVI valve is will seat on the green line, that is the basal structure. Why we are talking about this patient prosthetic mismatch is when you do a surgery, cut open the aorta, when you put a valve inside this one, because these valves have a stent and a sewing ring, this will encroach inside the left ventricular outflow and into aorta. If you see the manufacture, the companies usually give one size, but actual measurement if you put, for example, if the company is quoting 25 millimeter, the actual annulus, that is effective orifice area, will be 20. There will be a reduction of -36. So we have to do a aortic root enlargement if you want a bigger size valve in future. Example, if you want to do a TAVI, if you put a small valve like 21, it will be very difficult for them, and coronary anomalies, everything will be there, then it becomes a disaster. So this is what each company will give their effective orifice area, and we have to choose which one suits for this patient, and we have to plan the surgery. If you come to surgery, we have a different multiple options are there, and we have to, when you are planning for a surgery, when you see a patient, their age group, what is their age group, what is their expectation, they want a bioprosthetic valve, because this bioprosthetic and metallic valve, whether if a mechanical valve we are putting, they have to have a lifetime anticoagulation. That is the biggest headache for the patient, because they have to come on and off to the hospital to check their PTINR test, and accordingly we have to adjust the dosage. This is a lifelong headache. It is taking one disease and replacing that patient with another disease. So this bioprosthetic valve, in contrary, we can instead of mechanical valve, we can put a bioprosthetic valve. It requires a minimum of 3 months of anticoagulation. After that, the patient will be free of coming to the hospital other than regular checkup. But the problem is you cannot put the bioprosthetic valve in a very young patient, because it degenerates very early because of calcification, as Sir has told, aldehyde and other mechanisms which destroy the valve in a younger patient. So usual recommendation is above 65 years for a bioprosthetic valve. And whatever the valve which is used in TAVI, everything is a bioprosthetic valve, because here also we recommend a bioprosthetic valve even when they are female patient, they want to undergo any pregnancy or complete their responsibilities. We recommend a bioprosthetic valve. And most of the patient now, they are asking for a bioprosthetic valve. They are ready to undergo a second surgery rather than visiting the hospital and seeing the doctors in regular basis. So what are the options? We do have a lot of options for these patients, not only the stent and the sewing ring, which is the culprit for reducing the left ventricular outflow tract. We have, if the patient is less than 50 years, you have to give a recommendation for a mechanical valve. Still, that is the gold standard for them, because once the anticoagulation is lifelong, they will be free of this valve failure. But if it is a borderline gray zone between 50 to 70, mechanical bioprosthetic valve can be recommended. With or without root enlargement procedures has to be there. In the following slides you will understand what I am speaking. And if it is more than 70, definitely they have to undergo a bioprosthetic valve. And as I told, you can see the second picture, you have a stented valves. And if the stent and the sewing ring is a problem, you have a stentless valves are there, which are slowly withdrawn from the market. And we have sutureless valves. The second picture, you can see a sutureless valve, where it is between a stented valve and a TAVI, where we open the heart, just open the aorta, just put this sutureless valve. There is no need for suturing the valve and placing in that position. Just to do a balloon dilatation and come out immediately. Especially for a very sick patient, we opt for a sutureless valve. And recently we have come with the last valve, Inspirus Risalia, similar to what Sir has put today. This has an advantage. It is a bioprosthetic valve. Now we can replace this valve in its own size. For example, 23. If it fails after 15 years, just you can do a balloon dilatation of this and you put a TAVI inside this. So it is a expandable valve. Now if you expand in the first instant, it fails and aortic regurgitation will come. Once you put this valve now in its same position, then in future if you want to put a bigger valve, you can just open with a balloon and you can replace with a TAVI. So coming to the surgical perspective, this is the base of the heart which has taken a cross section of the heart. Whether you want to enlarge anteriorly or posteriorly. Posteriorly you can enlarge into 4 types, anteriorly 1. So all these things, unless you see an operative video, it will be very difficult for you to understand. I have shown only one specific simplified procedure operative video that gives a good clarity of what heart surgery is. Rather than seeing the pictures, it won't give a clarity. So just for completion, you open the aorta anteriorly into right ventricle also, you get a elliptical patch and put a bigger size valve. Posteriorly, you go into the in between left commissure and left coronary and non-coronary, you cut across in the next procedure 1 centimeter, and you can upgrade to one size bigger size valve. And this Boyang you can upsize to 2 to 3, and this Manogian you can upsize to 2. This commando procedure is the name itself implies that if it is a complicated thing, you go for a commando procedure. It is one of the very advanced procedure in cardiac surgery where it's done only in John Hopkins, like that Mayo Clinic or this thing. This where you cut across the mitral and aortic and convert that one into a single chamber. You for a replacement of double valve with the patch reconstruction with the pericardial patch. Usually it is done for a reoperation, or if there is a end-stage renal disease or mitral annular calcification or rheumatic. And incidentally, yesterday we had one patient which I have operated last year in Pondi, this commando surgery. So that patient echo, just we are playing here, Melitonia valve we have put 25 and 19 in mitral and aortic. So comparing all the procedures which I have told, the posterior enlargement, this Boyang procedure is less. It is not a complex procedure. You can upgrade to 4 sizes. The cross clamp and ischemic time for the heart is very less. All these things, unless you see a video, you won't understand. So just we'll pass over there. You cut into inverted Y, where you can see now. After arresting the heart, the aorta is cut open there. This is what Sir is also telling. This is the severely calcified aortic valve which is excised along with the calcium. Now we are sizing with the sizer. 19 is going with the restricted thing. I have told inverted Y cut is given here. This is going inside between the non-coronary and coronary commissure, left coronary, and we are changing the direction towards the left coronary. Similarly, on the right side, non-coronary is cut, sinus is cut, and we are just stopping short of perimembranous septum. If you go beyond, then there is a chance for conduction and block because the bundle goes beyond this one. Now we are sizing the patch which we have cut across, and you are just reconstructing the area which has been cut wide open so that bigger size valve can be accommodated. So this patch is reconstructed, and the left ventricular outflow tract and the aorta is widened. And the one good thing is, whatever the calcium, anything, for a surgeon it becomes a routine simple procedure because it is under your vision. We can completely take out all the calcium. Now after reconstruction of the patch, now we are sizing with the sizer. Now it is 23 is going very easily. This is what usually as Sir told that they won't take a suture. Now we are seeing and doing everything under our control. This is for aortic valve replacement with sutures, and we have other valves without sutures also, where we also open the aorta, just put it inside, and just with the balloon dilatation you open up the aorta. And you thread that to the valve. This is the bioprosthetic valve with the stent and the sewing ring. You lower down there and just make them to sit in its position. You are closing the aorta. So Boyang procedure, what you have seen is a easy procedure. It is reproducible. It is not a complex thing. Once you widen the aortic left ventricular outflow with the aorta, there is a chance, even if this valve, bioprosthetic valve, fails after 15 years, there is a chance for TAVI can be done in this valve. So the upsizing will be for this around 2 size. For example, if it is a 19, you can put a 23 valve. If it is a 23 annulus, you can put a 25. So when you should not do a Boyang procedure, when the aortomitral continuity has extensive calcium or the left ventricular outflow tract, what we are addressing here is the only the annular level stenosis. We are not addressing the left ventricular outflow tract obstruction. If there is a membrane or hypertrophied septum, we can excise and do a Boyang. Otherwise, left ventricular outflow tract has to be addressed with the Konarasthan, where you have to cut across the interventricular septum and you have to reconstruct. In past 2 years, we have done more than 12 cases of this aortic root enlargement, where usually these people are mostly female, obese, short stature, diabetes with the AF or associated chronic kidney diseases. They come with a small aortic left ventricular outflow tract and a small aorta, where you have to upsize that one and do a root enlargement procedure. Then we have to put a sizable valve to avoid patient prosthetic mismatch now and in future, with a possibility in thinking over replacing with a TAVI. So to summarize the event, when you come across a severe aortic stenosis, the first thing you have to do a transthoracic echo, and if it is more than 21 annulus, just to do a straightforward surgical AVR. Still it holds true for most of these cases. If it is less than 21, subject him for a transesophageal echo with a 3D reconstruction or CT scan, and evaluate still this patient is a low risk group. Usually TAVI is recommended for a fragile patient who is bedridden or with a severe comorbidities, but now the indications are stretched, but still this surgical AVR holds true for a lot of patients. If they are a low risk patient, still do a surgical AVR. The thing you should keep it in mind is there should not be any prosthetic patient mismatch. The future TAVI should be there in your mind. And if it is an intermediate risk, if they have associated coronary artery disease where the coronary artery bypass has to be done, or if the mitral valve has to be replaced or repaired, anything, you can opt for a surgical AVR. Because it is a combined procedure, you have to go only for a surgical AVR. There is no chance for TAVI. If they are high risk patient, too fragile, then you can do a TAVI. This is one of our patient which I have operated more than 1 year. She has undergone during her young age, for completing her family, she has undergone a bioprosthetic valve. After 15 years, she came to us with a valve failure, suctional valve damage with a severe aortic stenosis. Then we have to do a redo surgery. Redo surgery is not a very complicated surgery. It is done regularly. So sometimes these patients are very, very anxious to undergo a second surgery. I have done more than 5 times for a single patient. So redo is not a problem for any patient, provided they withstand. The mental status is very important. If they withstand the complicated surgery, then we can go ahead and remove the old failing valve, and we can do a valve replacement once again in this patient, considering the future, because she has opted, she is a teacher from Andaman, she has opted for a bioprosthetic valve. So we have to, once again I have to do a bioprosthetic valve, but this time instead of putting a same size valve, I have enlarged the root, and I have done redo surgery with the bigger size valve. If it fails in future, there is a chance for either she wants a third surgery or a TAVI.
Myself, Sangeeta Mich, a teacher by profession from an island, Andaman and Nicobar, which is considered as one of the remote islands, wants to express my sincere gratitude towards Dr. Gopal Murugesan sir, who deserve the whole soul credit of treating me. Myself was diagnosed as suffering from degenerative aortic bioprosthesis with increased gradient. मेरा सबसे पहला ऑपरेशन 2008 में हुआ था. उसके बाद रिसेंटली 2025 में मेरा दूसरा ऑपरेशन हुआ है. So I would like to express my heartfelt gratitude to the Dr. Gopal Murugesan sir, who in spite of being so far from this island physically, handled my case and helped me recover. From time to time he review my reports and...
Thank you. If there is any questions, I am very welcome to answer. No questions?
Thank you.
Thank you so much, sir. Thank you so much, sir, for sharing your words of wisdom today. So on that note, I think we come to an end of our session for an enlightening session today. So I call upon Dr. Selvam, our medical director, to give us the vote of thanks for today's day.
Good afternoon, everyone. On behalf of Vinayaka Mission Superspeciality Hospital, it is my privilege to propose the vote of thanks for today's enlightening CME program and the TAVR story, Innovation and the Road Ahead. First and foremost, I would like to express our heartfelt gratitude to our Chairman, Madam Chairman, and our beloved CSO, Suresh Samuel Sir, and our guest speaker, Dr. Sengottuvelu. Just now he left, Senior Consultant, Interventional Cardiologist from Apollo Hospital. Thank you, sir, for sharing your vast experience and valuable insights into the evolving field of TAVR. Your talk has been truly inspiring and academically enriching for all of us. I also extend our sincere thanks to Dr. Gopal Murugesan, Chief and Senior Consultant Cardiovascular Thoracic Surgeon, for his excellent presentation on the management of small aortic root and aortic enlargement, and our most thank for our cardiologist, Dr. Sridhar, and his team for this wonderful presentation. My special appreciation goes to all the consultants, doctors, and participants who took time for their busy schedules to attend this program and actively engage in the discussions. I would also like to acknowledge the efforts from the wonderful team led by our COO, Mr. Manimaran sir, the organizing team, hospital administration, cath lab team, especially Mr. Kasi, marketing team, and supporting staff whose dedication made this program a success. Thank you. Thank you, one and all. Thanks a lot.
Okay, now let's all rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे